I'm going to focus my pieces on what we've done in Washington. So in the fall of 2021, with Operation Allies Welcome, we combined efforts with our Afghan American community and Muslim American community to establish a joint coordinated effort. As part of that effort, we established different working groups, including a working group on health and mental health. And as a response, our office and our Department of Health and our State Refugee Health Coordinator worked with ethnic Afghan community-based organizations to lead a group to focus on how do we address health disparities as well as mental health needs. These subgroups comprised our clinical health partners and refugee health screenings, and we also involved our refugee mental health agencies and community partners that had experience serving the Afghan community. The ethnic CBOs were able to provide real-time challenges that were being experienced by the community and the cultural context to our partners about the challenges seen within the health systems. We met on a weekly basis and identified specific goals to troubleshoot any systemic challenges and completed a community scan to identify areas of need. So what did we find in our community scan? The regular communication with the subgroup partners combined with close feedback loop from our ethnic community-based organization allowed us to build and invest in layered programs and services to support the Afghan communities. One example of a systems level is that our clinical partners and refugee health screening providers would have patients with varying mental health needs based on their urgency, intensity, language, and they did not know where to refer patients for the most appropriate care. So we invested in mental health navigation and a clearinghouse to connect clients to culturally and linguistically responsive emotional support services based on urgency, intensity, and language. We will also be adding a Washington Refugee Mental Health Coordinator with a focus on coordinating partnerships, training needs, and technical assistance. At the community level, our ethnic community-based organizations gathered arrivals at mosques regularly and identified a critical need for the lack of support for men. We invested then in Afghan's men's support group focused on community connections, adjustment to the United States, and emotional wellness. And one federally qualified health center also received a large refugee patient pool, identified a high volume of pregnant women who were in their third trimester. And it was difficult to provide a provider who would take them in. And so we were able to invest in a clinic that provided primary care access for pregnant women and wraparound supports to offer connection to care and resources. And this is critical for well-being as well. Some of the best practices that we found was communication. We hear it time and time again, but regular communication with community partners and bringing the ethnic community-based organizations together to troubleshoot existing challenges and identifying gaps in services was critical for us to be able to make informed and strategic investments into health and mental health programs and services. And since we were having an emergency response and we met weekly, it was very intense, but we identified very clear and specific goals. We also were able to invest in layers of support that has been crucial to ensure clients have multiple entry points into the ecosystem. And so this included partnering with our Afghan Health Initiative, as well as other organizations that really focus on how to help people navigate the healthcare and mental health care systems. And lastly, with sustainability in mind, we added or built an existing program is critical. We really focused on the ecosystem and how can we be connected to the larger healthcare and mental health partnerships and programs in Washington. There were also many challenges along the way. So the high rapid arrivals really created a challenge for people to ramp up staffing and support. The healthcare system was recovering from the pandemic, which created a systems level challenge. Many of our refugee arrivals were experiencing high levels of trauma because they were coming directly from the conflict zone without much time in between to process. And this was very overwhelming for the entire community at large. In Washington, we had a very large existing Afghan community, and I think that they wrapped around the community, but it was also very traumatizing for them as well. And on a client level, unless there were any complex medical conditions, most individuals prioritize basic needs first prior to health, which is understandable. But that meant that people were really looking to address their housing, their legal immigration issues, their lack of documentation, as well as so many other competing priorities. Ultimately, I think as a state refugee coordinator in Washington, the lessons that we learned is that refugee resettlement happens at the local level, and working to coordinate together is the critical piece to success and ensuring that refugees achieve economic stability and wellness in their communities.
My name is Laura McLashin. I am the New Hampshire State Refugee Health Coordinator. I'm also past chair of the Association of Refugee Health Coordinators. Thanks for queuing up my slides. I'm actually going to go off camera so I can reference my notes at the same time. So just as Sarah mentioned, just as each state or territory has a state refugee coordinator, the same goes for state refugee health coordinators. So state refugee health coordinators administer the refugee health programs in their respective states, including overseeing the recommended initial domestic refugee screening for all arrivals. And so I belong to the Association of Refugee Health Coordinators. So we're kind of a sister organization to SCORR, national affinity organization that we work with partners, both public and private at all levels, federal, state, and local. We strive to ensure that all arrivals receive the best healthcare possible in a timely, culturally, and linguistically appropriate manner. So state refugee health coordinators and state refugee coordinators are really partners. Oftentimes we're located in the same offices, although there are a number of state refugee health coordinators that are located in public health. So moving right along, in this part, I'm going to give a broad overview of the refugee health promotion funds that most states receive from the Federal Office of Refugee Resettlement. So just this slide is kind of FYI in case you'd like to dig into it further. This slide lists all the relevant ORR policy and Dear Colleague letters that outline the parameters of the funds, and these are all available on the ORR website. Next slide, please. So historically, refugee health promotion consisted of one grant. Recently, though, with the arrivals of the Afghans, two subcategories were created, and that was Afghan health promotion and then a mental health initiative within the refugee health promotion. We're going to refer to it as REMI. So next slide, please. So the overarching goal of refugee health promotion is to promote the health and well-being of refugees and other ORR eligible populations by providing opportunities to increase health literacy, coordinating healthcare, and organizing wellness groups. Next slide. So allowable refugee health promotion activities include health education classes, targeted health outreach to individuals, medical and mental health navigation and support, and adjustment groups, skill building networks, and peer support meetings. As you can probably imagine, many of the arrivals are coming from places where their health systems look nothing like the US healthcare system. Our system is incredibly complicated. And so these services are very much needed to be able to connect people to care and to give them the education and skills they need to be able to ultimately navigate the system on their own. Next slide, please. So as for eligible populations, under the general refugee health promotion, this would be all individuals who are eligible for services under ORR's refugee resettlement program. They need to be within their first 5 years of eligibility, And we really put a priority on those who have the most persistent, pressing, or underserved health needs. And I will just mention that the Afghan health promotion piece has the exact same goals, scope, and activities, but it's just targeted for the Afghan populations. Next slide. So now I'm just going to turn and focus specifically on the mental health initiative funds that are under refugee health promotion. So the mental health initiative piece does serve all ORR populations, but it does have unique goals, scope of services, and activities. So the goal overall is to build capacity within communities to address mental health needs of refugee populations, including help overcoming stigmas associated with mental health care, and also creating opportunities for social engagement to reduce isolation. And ORR specifies that the approach that the states use should be client-centered, trauma-informed, strengths-based, and culturally and linguistically appropriate. Next slide, please. So the specific target areas of REMI are increasing mental health literacy, and this includes outreach to mainstream mental health providers, developing training curriculums, increasing the pool of mental health first aid instructors, outreach and education for refugees. Also includes coordinating mental health care for those who need it, linking to mental health service providers, addressing language barriers to the mental health services, and organizing wellness groups. Next slide. And it's really important to note that the use of refugee health promotion and REMI funds really does vary across the country. It's very much dependent on the specific population needs in that particular state and state-specific dynamics. So the way that we are using refugee health promotion and REMI funds in New Hampshire may look different from the way the funds are being used in, say, North Carolina, North Dakota, or Ohio, though there may be some overlaps. But we all do adhere to the same broad parameters that I outlined earlier. So the refugee health promotion funds can be administered either by a state refugee coordinator or a state refugee health coordinator. Some states did use the general refugee health promotion funds for mental health programming prior to the REMI funding, which came into effect within the past year, but not all. States often pass through funds to a variety of partners to support community integration. So for example, in New Hampshire, we do pass it through to our 2 local resettlement agencies. Funds can also be passed through to community agencies or ethnic community-based organizations. Next slide. And finally, this is my final slide, and I would like to end just by highlighting all of the very positive things that have developed over the past year and a half or so. Just want to note, we are really moving in a very positive direction. This past year plus has seen major increases in refugee health promotion and mental health funds, as well as opportunities. As Sarah also mentioned, we've really increased interagency and cross-collaborative partnership activities with our federal, national, state partners. We've increased our regular interagency meetings between ARC, SCORR, federal partnership leadership. This would include PRM, Department of Homeland Security, USCIS, ORR, and CDC. Both PRM and ORR are expanding staff with health and mental health portfolios. We've heard that a federal refugee mental health work group is in the process of being established. And the Society of Refugee Health Providers has recently established new committees on both health promotion as well as mental wellness. So with those opportunities, there are also challenges. As you may gather, some of the different categories and funding streams are complicated. And as is the case all over, there are workforce and capacity issues. It's really hard sometimes to find willing partners. Turnover at the state level, at the resettlement agency level, has led to just a loss of knowledge and experience just at all levels. And we really need to focus on rebuilding that. At the same time, this increased funding became available, our systems were also overwhelmed by COVID and everything else. And we didn't really have advance notice to plan. So it's necessary to balance capacity building versus addressing the immediate needs. But there is a lot of planning and strategizing going on around the US.
My name is Boyana Zoris Martinez. I wear several hats as many of the state refugee coordinators and state refugee health coordinators, but for the sake of today, I am the Wisconsin State Refugee Coordinator. And just to mention, I also serve as the Director of the Bureau of Refugee Programs with the Wisconsin Department of Children and Families. And I have the pleasure of serving on the SCORR Executive Board with Sarah and some of my other colleagues from across the country. So it is a pleasure and honor to be here with you today. However, I'm not alone. I am the face, but really the brain and everything else is behind the scenes, and maybe they'll show up at some point here, but our State Refugee Health Coordinator, Savitri Saring, is on as well, and so is Janice Beers, who is the Department of Children and Families Policy Advisor for New American Integration, and they really were the ones who are doing the work and have a great vision for a lot of this work that I'm going to be talking about today. I just get to highlight it. So just a little bit, Sarah and Laura gave an awesome background and everything that you're going to need to know in relations to how I'm going to present some of the things that are happening in Wisconsin. You're going to be able to connect the dots as to how things really work in one of the states. So, but just to give a little bit of the background on me, I am a former refugee myself. I came to the United States back in 1999 as a refugee from former Yugoslavia. And I went through my own path through resettlement of not knowing the language and not knowing anything about the culture and just so many different elements that are similar to a refugee story. And I worked in refugee resettlement for a number of years. In fact, if I'm thinking about health and mental health and in general the service provision as it relates to trauma-informed care way back then when I arrived and even when I worked in direct service provision and in comparison to where we are today, it's night and day. I often point out that I remember when 9/11 happened, that there was just a lot of chaos happening around how do we support the community who's reliving some of this experience. And today we have a lot more resources to deal with those types of things. So it is great to see where we once were to where we are today. And as I said, right now I serve as the State Refugee Coordinator, helping to coordinate the refugee resettlement response in the state, in our state, and collaborate with the many partners who provide direct services. So just like many other states, Wisconsin has been doing refugee resettlement formally since 1975, so almost 50 years. And we have evolved to be a very effective in the programming that we, very effective state in the programming that we do have in our state. We're a state administered state, to the point that Sarah was making earlier about the replacement designee in state administered states. We received federal funding up until about a month ago. We were 100% federally funded by the Office of Refugee Resettlement. But now we do have a little bit, not in comparison to Washington, but a little bit of that state funding for some career development for refugee resettlement agencies to help the newly arrived refugees with career development. But as I said, for the most part, we are federally funded. We have all the programs that have been mentioned, with the exception of the unaccompanied refugee minor. That's the only program that Wisconsin is not currently administering, but everything else has been part of our fabric as well. We're somewhere in terms of arrivals, but also in terms of funding between the 20th and the 24th place, depending on a year. But we're about 1 to 2% of the federal arrivals, of the national arrivals, is what we receive here in Wisconsin. In relations to the mental health and trauma-informed care, when we were talking about this presentation, really focusing on what is it that we as a state, as one state, do to help put the funding to good use. I received a few questions, and that's really how I went by. So I'm going to go through some of the questions that I received and help answer them to, again, relate to how we administer our programs in Wisconsin and how we're spending our funding. So I'm going to ask Elisa to please go to the next slide and to try to answer that first question. So which programs and services has the Wisconsin Office of the State Refugee Coordinator distributed funding from ORR for trauma-informed mental health services? As it was mentioned, especially in the last year, within the last year, there has been some additional Afghan supplemental funding. So the Afghan Refugee Health Promotion and Refugee Support Services were the two of the Afghan additional supplemental funding programs that we have been utilizing in our state by doing the adjustment support groups I'm going to talk about in a minute, and then also some of the immigration-related legal assistance through the Refugee Support Services, specifically for Afghans. And of course, Laura talked about REMI. REMI is the Refugee Mental Health Initiative and Refugee Mental Health Initiative Capacity Building. There were two different agencies in one in Milwaukee and one in the Madison area, and I'm going to actually back up a little bit and just to give you a little bit of geography of our state in case you're not familiar, but Milwaukee receives about, or has traditionally, historically received anywhere between 50 and 70% of all Wisconsin refugees. So Milwaukee has always been a hub. But most recently, with the opening of some of the new resettlement sites in northern or central Wisconsin, and also in the Green Bay area, which is in the Fox Valley area of Wisconsin, that number has gone down slightly, but still Milwaukee is still that hub of welcoming the most refugees in our state. And then followed by the Fox Valley area of Oshkosh, Appleton, and Green Bay, and then Madison is the third largest. So in Madison, they're utilizing the Refugee Mental Health Initiative, and I'll tell you a little bit more about that as to what that means through the mentorship program. And then also in Milwaukee, a long-standing stakeholder, a partner, a contractor of ours, Dr. Sebastian, in his family psychology practice, has been very heavily involved in mental health of refugees and immigrants, has received funding for our REMI capacity building. And then Refugee Health Promotion Targeting Afghan Family Strengthening Initiative, which I know is the new buzzword. There's a lot of people that are talking about the family strengthening, and I know that in Wisconsin, we're also looking into piloting that by using some models from some of the other states. Next slide, please. So the second question goes back to that first one, but it specifically is asking about examples of how we're doing that, how we're utilizing that funding. So as I mentioned, in Madison, there is a refugee mentorship program with funding from REMI. And what they're doing is a 6-month mentorship program for a paired mentor and mentee, where it's really mentee driven. So it can be a variety of different things in which a mentee may need help and to focus on. So it could be, you know, anything that is related to family strengthening, integration, self-sufficiency, and so on. However, there's always some sort of a mental health and trauma-informed component to it, and that's the lens that that Jewish Social Services decided to really focus on. So this is an important part of mental health, no matter what the activities are, because they involve things like reducing stress, isolation, and increasing skills to make life easier and less stressful and all over, and of course, improve well-being. So those are the specific components that, again, JSS is concentrating on. There's a number of different Afghan support groups that have been happening over the last year across the state, and most of them, again, started in 2021. So, for example, they are also focusing on self-care, emotional support, decreasing isolation, adapting and navigating to U.S. culture, navigating systems, and so on. And many different sites, as I said, pretty much all the sites in Wisconsin have been focusing on these support groups. So Catholic Charities in Green Bay, World Relief in the Fox Valley area, they started doing that soon after some of the first Afghan arrivals. Aurora Walker's Point is a clinic in Milwaukee who has been leading the efforts in providing care from refugee medical screening to health promotion for refugees who have been arriving in that part of the state. And so what they do, they lead a weekly walk with Afghan women. And in addition to that, they're starting 2 new support groups. One for a support group for women who had to leave their children behind in Afghanistan. And this is led by a female counseling intern and supervised by a male a psychiatric nurse practitioner who, again, has been leading a lot of the efforts in that clinic for refugees. And then there's a men's support group that will be more general in nature. So it's not focusing on a specific topic, but kind of all encompassing and narrowing on specific needs of, again, navigating the system, learning about the culture and some of the things with again, how the United States systems and health and mental health function. And this is led by a male Afghan CHW, so community health worker, partner with a male psychiatric nurse practitioner again. Ascensional Saints, which is another clinic of ours that has been specializing in providing care for refugees, is doing or did a Afghan youth summer camp. And from what I'm hearing, it was amazing. So now going back from the support groups to a RISE Law Center, and Abuse Wisconsin and Madison received some of the supplemental appropriation funds to fund immigration-related legal assistance through trauma-informed services. So again, looking at that mental health lens. And then there's been plenty of trauma-informed care training for RA staff, so resettlement agency staff throughout the country. And that's something that I don't think is just new for what's been happening in the last year, but we have been doing this for a number of years. And again, led by our state refugee health coordinator, those efforts. And then the Afghan Family Strengthening Pilot Project. Sessions that focus on assessing family strengths and relationships, improving parenting skills, reducing stress, improving self-management of symptoms, navigating the U.S. health and education system, and facilitating linkages to care. Lutheran Social Services is one of the LIRS affiliates in Milwaukee, has been taking a lead in looking as to how to pilot this. And again, they're modeling this after some of the other states that may have already implemented it and looking as to how it would apply for the specific population that's in our area. As you might know, a lot of the funding that was received for the Afghans is to specifically serve the Afghans, but we're always looking as to what are some of the things that we can do to mirror to help and assist other populations, because everyone needs mental health services, and we need to make sure that our staff is trauma-informed and that we are able and equipped to serve all populations. Next slide, please. And then in addition to that, as I said, mental health, and as you probably all know, is a huge component of the service provision and a much needed one, especially early on after arrival. There are a number of different efforts that are happening across the state. I know we're very Milwaukee heavy because, again, Milwaukee is the largest site, but there are other areas that are doing just things that are just as amazing. So Hanan Refugee Relief Group is one of the alternative model sites. In fact, they were partnering with Islamic Relief through the institutional partnership to welcome Afghans into this community. They're collaborating with a counseling center, a Zena Counseling Center in Milwaukee, for holistic services that integrate mental health services. And this one agency, Hanan Refugee Relief Group, has really been focused on mental health from day one. That has been their focus for all different groups, men, women, children, since arrival. So they're really leading those efforts. I mentioned the psychiatric nurse practitioner at Aurora Walker's Point, which is one of the clinics. And then several other clinical psychologists are engaging in individual therapy, mental health education, and family case management with refugee clients. We're very lucky that in Milwaukee we have these two clinics who are seeing the need and who are willing to put any of their private funding and engage with other resources to make sure that mental health becomes a priority. So in addition to refugee medical screening, health promotion, wellness, and all these other things, they're really seeing the mental health component be a priority. Milwaukee Muslim Women's Coalition is another organization that's been a great stakeholder of ours and a partner of ours. they host sessions educating mainstream providers on mental health issues specific to Muslim refugees. And again, that's the population we've been seeing lately. We also have a community action program agency who engage in a community sponsorship model that has resettled some families in southwest part of the state, and who is doing amazing things to partner with mental health providers at UWM to offer a conference that's specific to mothers and children. And then Medical College of Wisconsin, again, doing a lot of webinars to make sure that, again, they educate the public and other populations about the trauma that refugees have undergone. I'll go through the next couple of slides very fast because I understand we are over time. So can you get me to the next one, please? Thank you. And then Savage Tree has done a great job, our state refugee health coordinator, in starting a global mental health network in Wisconsin. The conversation started in 2016 and went into 2017. And there's been some great things that have been done, including some of the mental health first aid and suicide prevention for question, persuade, and refer trainings. I've been a part of those trainings. They're very intense and telling as to some of the things that we need to concentrate on to help our newly arrived refugees get through some of the challenges. And because of COVID and many other factors, some of the efforts in putting together that global effort have been paused, but we are continuing. And then the last thing I will say is that in the next slide, I was asked about the Refugee Advisory Board and the Refugee Advisory Board's role in helping to inform decisions for the state refugee coordinator in how they allocate funding and the programming. And so we have a Refugee Advisory Council, which is a team of leaders of these different service provider organizations who are helping, again, the state refugee coordinator to advise on all the issues, patterns, best practices, and so on, so that they can inform those decisions. However, they're not the ones making the programmatic and funding decisions, the state refugee coordinator's offices, but they are definitely helping in that. And then we meet quarterly, and these agencies, again, may or may not be funded by the state refugee office, but it's a great collaboration on all fronts, and then, of course, on mental health and trauma-informed care in Wisconsin.
Hi, everyone. My name is Amal Hassan, and I'm very happy to be here with all of you guys today and get to hear a lot of the great work that my colleagues who presented are doing. I will just give a little bit of brief, like a minute or two, about what CVT, what CVT does. CVT was founded in 1985 as a result of a government task force. Really, the goal was what are the best way to support refugees and asylum seekers and understanding the mental health and the healthcare system in America, and helping the newest refugees that were arriving at that time. It is the first and the largest in the United States, and we're the third largest treatment center in the world. CVT is a human rights-based organization that is headquartered in Minnesota. Our mission is to heal wounds of torture on individuals, their families, and their communities, and to end torture worldwide. We're based in Arizona, Minnesota, Georgia, Atlanta, Georgia, DC, and then Ethiopia, Kenya, Uganda, and Jordan, and Iraq as well. CVT primarily is really well known for its work in clinical expertise in terms of providing support and research around how refugees have suffered physical, historical, and/or psychological. And often those trauma are rooted in the action of police or a government force in their own country. We work with clients who have dealt with similar common experiences of most refugees: death of families, beating, rape, power, corruptions, often experiencing a significant and a complex trauma. We know that trauma is life-threatening, overwhelming, And for refugees, it's not a singular event. It has an intergenerational effect. When we talk about the pre-flight, flight, and post-flight, each stage is associated with a host of traumatic experience. But often we hear from our clients that the post-flight is often ignored and underestimated. People just assume that if you go to a host country like United States, that all your problems are behind you. People are expect you to function and do things right away because now you're in a safe place. But people are still often dealing with ongoing trauma back home. They're still having to hear from their loved ones that they're dying, losing land, and in most cases, parents are experiencing or children are experiencing traumatic separation. They're also are vulnerable to the U.S. When they come to USA. They're also vulnerable to living in poverty and dealing with racism or Islamophobia or religion phobia, all of the isms. So CVT, as I mentioned, is really well known for its clinical expertise, as there are a lot of, they provide a lot of trauma-based treatment and psychotherapy and targeted case management. In 2015, DHS Minnesota wanted to give the grant to the CVT to identify why so many refugees and asylum seekers were leaving St. Cloud and going to the cities, which is an hour and 30 minutes to get psychotherapy. And they wanted CVT to define what was happening in St. Cloud that these individuals were not seeking support from therapists over there. As you know, a lot of the refugee and asylum seeker communities depend on word of mouth. Often their friends and families are telling them that the therapists in Minneapolis are trained, they recognize our culture, they recognize what we suffer, so they're not having to train the therapists. So with that grant, CVT was able to identify and figure out a way to improve coordination and integration of behavioral health services for war traumatized refugees and to help the newest refugees that were living in St. Cloud, Minnesota. The grant was the first step to really start offering community-based support. CVT didn't dabble on that until this grant, because this grant has allowed us to connect with providers and refugee leaders to collaboratively develop solutions and build relationship, regardless of other things that were happening in terms of Islamophobia and racism. So with that grant of 2015, CVT wanted to continue to do this work. We used the need assessment to identify what are the community needs, how to best help facilitate services and improve quality of cultural competency when delivering psychotherapy, targeted case management, or even working with seeking primary care help. We needed to identify funding was another big issue. Who can help us really push this effort forward? So identifying local foundations that provide the support, working with other community-based organizations. We started hosting multiple different events, as CVT was known for one thing. Now we're moving on to the community-based support. So trying to inform all of our stakeholders, our new effort to do community-related work. So with that, with the community need assessment, we were able to identify some of the big needs that the community needed, which was mental health awareness, parenting, informal counseling, social support, and community education. And we really relied on building those relationships and trust, and not so much onto the clinical expertise. We used the trauma-informed lenses, but we didn't walk into the community being the expert. We were part of the conversations, and we related to community members as peers rather than as clients. That is something that we still do and engage. We treat our community members as survivors, as peers, and often you don't hear us using language like clients. That helped us enable multiple relationships with both the refugee community, but also with health and other social services. And some of the barriers that we really faced, funding was always an issue. So there was a lot of going out and meeting with funders and talking about our programs. But with pandemic, we were not able to continue the services the way we did face-to-face. We saw that the community that we were serving also didn't know how to access Zoom or Google. So we had to come up with other creative ways to engage the community. And what we did was provide an education and intervention, like thinking, like there's a platform, the Somalian radio, and then Hidik TV. So going out there doing parenting or parent wellness care, and those cost a lot of money. So we then connected with our local counties to access some of the funding that they have got directly for COVID related to provide that. And we also collaborated with the local law enforcement, anyone that is really interested in getting it out there and sending out the message to the refugee community that they're in partnership. They want to be in partner with the community and helping the community move forward. We meet weekly as a team to really just identify what are some things that we can do together and who can support this effort. And because of that, we were able to get most of our things funded. And if we didn't, we figured out another agency that could lead it and we could be the support or the training them